Welcome, welcome, welcome. We're going to let people flow in as we do in this virtual world that we're in right now. Welcome to This Clinical Life. My name is Stephen Beeson. I am host of This Clinical Life and founder of Practicing Excellence. That is the sponsor of this particular podcast. In this podcast, we sort of explore the transformational impact of developing your healthcare workforce, one of the most powerful and almost entirely untapped mechanisms of positive change. And so today's guest, really excited, a little bit intimidated by this particular guest, Dr. Shikha Jain, who is going to make you think and reflect, what am I doing in my life after we have a chance to chat with her a little bit? Because she has some serious rocket fuel in terms of the impact that she's making on the world. And I know that's very qualitative, but I'm going to do a formal introduction here and we'll dive in. But Shikha, thank you for being here.
Thank you so much for having me.
Oh, you bet, you bet. So Shikha Jain is a board-certified hematologist and holds several prominent roles, including tenured associate professor of medicine and oncology at the University of Illinois Cancer Center in Chicago. She is founder and CEO of this amazing advocacy group called Impact that did some incredible work during COVID that we'll talk about a little bit. She is founder and president of Women in Medicine, and we were just talking about their annual summit that is coming up. So she'll share a little bit about that, where a growing body of people are attending, advancing gender equity that we'll have a chance to speak about. She's also host of the Oncology Overdrive podcast that explores modern healthcare through the lens of our ever-evolving world, that I've had a chance to be a guest on that. It's an amazing podcast. And she's also been one of our faculty members at Practicing Excellence and helping with our diversity, equity, inclusion content, for which she did a fantastic job. So again, Shikha, thank you for being here. And before we begin, just a couple of warm-up things. I'm going to have people, if you can, jump into the chat and let us know where you're viewing from, just so we can get a sense of the geography and get some names up in the chat. But just drop into the chat where you're watching from. All right, Seattle, New Jersey, Illinois, Detroit, Akron, Shreveport, Marlton, Portland, Maine, all over the place. California, fantastic. So I'm going to begin this process asking Shikha your story and where you came from. You clearly are not only your central role as a hematologist oncologist seeing patients, but you've done a variety of different channels, making a difference in the world of healthcare and beyond, with Women in Medicine, your Impact group, and your TED Talks, and all that you've done to sort of advance the things that you really believe in. Tell us a little bit about your story and sort of how you got here.
Well, first, thank you so much for having me, and you are far too kind in how you introduced me. So thank you very much for that. So, my story is interesting. I was born in New Jersey. A lot of people don't know that. I was born in New Jersey and then my parents moved me to Kalamazoo when I was 6 months old. I grew up in Kalamazoo. I always knew I wanted to be a doctor. I kind of had this feeling that I always wanted to be a doctor. My dad is a surgeon. If you've heard any of my talks, I mention my dad and my mom all the time, because I would not be where I am today without their support when I was a child and their continued support now. Family to me is very important. So my dad's a surgeon. I used to go round with him in the hospital on the weekends when I was a kid, back when you were allowed to do that, and thought I was going to be a surgeon, loved seeing patients. Went to the University of Chicago, met some resistance from people saying, oh, you're really fun. You should go into marketing or advertising or party planning. Had some mentors tell me that I shouldn't be a doctor because I wasn't smart enough. So thought I might go into advertising for a little bit, and realized my real passion was in science, medicine, and clinical care. So fast forward many, many years, I decided to become a hematology oncology physician, did the majority of my training in Chicago. And one fun fact about me, my husband and I did spend a year doing locum tenens work in New Zealand. So between residency and fellowship, we actually worked in New Zealand for a year, which was the coolest thing we ever did. Highly recommend anybody who wants to do that to reach out to me because it was so cool. And came back, did our fellowship. And, I'm now doing a lot of things that you mentioned that I never would have imagined I would be doing. If you had told me 10 years ago that I would start the Women in Medicine nonprofit, I would launch the Women in Medicine Summit, I would become a regular news contributor, I would be on a task force by the Department of Defense for addressing social media misinformation. I mean, these are things that were not things that I had thought of. I thought I was going to be a doctor, I was going to see patients, and that was the end of it. And now I've turned into somebody who does advocacy work, who, goes and does some lobbying for patients. I do all of this public facing work, which is stuff that I'd never really thought I would be doing. And, I started a lot of these things, these organizations and these initiatives, because I realized as I went through my life that a lot of those barriers and people telling me that I couldn't do things wasn't because I wasn't good enough. It's because systemic implicit bias and just the way society often views women and women in medicine, especially, were a big part of the reason why I was constantly doubting myself, why I was constantly thinking I wasn't good enough for medicine, why I was never going to be a doctor. And luckily for me, I fall back on my family. They have been my constant support, and they are the reason that I've been as successful as I am, because they've the ones who continually said, no, you can do this. Don't listen to the haters. Just keep moving forward. And so my motto now is, you think I can't do something? Watch me.
Well, and having watched you over the last couple of years and seeing you as our faculty and watched your TED Talks and been a part of your podcast and everything that you stand for, that engine that drove you to become where you are is such an important approach to our industry, not just in healthcare, but in other places. So I really want to begin to speak in this podcast about this idea of gender equity. And the data is overwhelming. And I had a chance through you and many others to sort of dive into it while we were building content around it. But I want you to get people up to speed in terms of where we are today in regards to gender equity and how it's manifesting with our healthcare workforce, sort of the objective kind of data, what we're seeing right now.
Yeah, so everybody should care about gender equity because it's impacting every single aspect of healthcare. So what we've seen over the years, and this is not a new problem, this has been in existence since healthcare was created, because women were not in the healthcare system when the systems were created. What we are seeing now in 2024, we're still seeing a significant pay gap. So study after study shows women and men doing equivalent work, spending equivalent amount of time, doing equivalent procedures or seeing equivalent patients, women are getting paid less than men. There's a lot of reasons for that. One of those reasons is women in general are often voluntold to do work or serve on committees that is very important for the organization or the institution, or retention of faculty or retention of people, and that work is uncompensated. So women get relegated to a lot of uncompensated, unappreciated tasks that actually are necessary tasks that need to be done, but they really should be compensated. So that the pay gap is a huge component. A second really big issue, we are seeing a huge gap persist in leadership. So whether you're looking in academia or you're looking in the community, or if you're looking in hospitals, the leadership gap is pervasive. And it's not because there aren't ambitious women. It's not because these women don't want to have these positions. It's because they're often overlooked, they are ignored, or they are really just told you're not right for this position because you just had a baby or you're going to have a baby. I mean, I personally have had people tell me when I was interviewing for a job, oh, well, you're going to have kids, so you should only work here part-time. I had one person tell me when I was negotiating for a salary, say to me, oh, well, your husband works, so why do you need to be compensated for your time? And I said, well, because my husband's not doing the work that I'm doing, and I should get compensated for the work that I'm doing. So there's a lot of implicit and explicit bias that really lends itself to this leadership gap. And again, it's not because there aren't really strong, ambitious, brilliant women, but they just aren't being given the opportunity because people fall back into their normal habits of going to the same pool. Then you talk about academic publications, research grants. I mean, any aspect of healthcare, you can find data and data and data showing that these disparities not only exist, they're not closing at a rapid enough rate. And we are seeing women leave healthcare altogether because of burnout. And the burnout is fueled by working 10 times harder than their colleagues and getting 10 times less recognition for it. McKinsey came out with a study showing that this is the case in the corporate world, and it is very applicable in the medical world to even more of a degree, because in the medical world, we also often are, instead of being called doctor, we're called by first name. That untitling actually has been shown to decrease opportunities. We are often, there's sexual harassment, there's harassment, there's bullying. There's a hierarchical structure that exists within our healthcare system that makes it very difficult oftentimes for women to stay. And women are often the ones who are punished when they report these types of things. So that's just a small snippet of the gender inequities, and it's resulting in brilliant, ambitious, excellent clinicians leaving our healthcare workforce, which is not okay.
There's another body of literature that I want to be able to review with you. And I want to be able to ask the audience. We're going to reserve like the last 10 or 15 minutes for Q&A. So if there are questions that bubble up for Dr. Jain during the course of this, then drop them in the chat and we'll have a chance to sort of close our segment with that. The next question that I have is, this is just not women in medicine advancing against a headwind for a variety of different reasons, losing opportunity and losing the potential contribution for what they have to offer and being underrepresented in leadership. There's, as you so well articulated, that is persistent for a host of reasons. The other place where it's manifesting is actually in the exam room. And so talk a little bit about that in terms of how women are treated in terms of the percentage that are getting evidence-based care to optimize a clinical outcome. Talk a little bit about that.
So I'm so glad you brought that up, because there was actually, I'm going to talk about this in a couple of different ways. So one, there was a study that just came out, again, showing that women physicians have better outcomes than their male colleagues. And I want to emphasize something. This is not an us versus them situation. I love my male colleagues. We work really well together. The point is, there have been numerous studies that have shown women in actuality have less readmission rates with patients. They have lower mortality and morbidity when they operate on patients. There's data that shows that the care that women physicians is providing is exceptional. So I put that out there because there's no question that women doctors aren't fantastic. The other challenge becomes, there's been studies showing women physicians actually spend more time on the electronic medical record, partially because they get more questions from patients, they get more detailed questions. Maybe patients feel more comfortable sending these messages to their female physicians. So I think that there's a lot to be said for the way clinical care is delivered by these women in healthcare. The challenge becomes, even in a clinical setting, women are more likely to be harassed by patients and by clinicians and by colleagues. I've had to stand up for my students and my residents before, where a patient will continually say girly or say, call my resident by her first name and call the male medical student by Dr. So-and-so. So, in the exam room, these things play out very often as well. It's not just the leadership gap and the pay gap. It's also how we're being treated on a day-to-day basis. And all of that fuels burnout, and it results, again, in women leaving medicine.
And there's even a further cascade. And I just read an article because, you prepare for the podcast and I want to know as much as I can about the chronic disease management, as you had articulated. It is pretty compelling in regards to objective quality metrics in women physician compared to men physicians. And I think that there's also interesting studies looking at the collaborative spirit, the psychological safety, and the receptiveness to information, the sort of the growth mindset, the cues that women may be giving that allow for activation of patients to participate in care, which ultimately is the mechanism by which to create a quality outcome. So it's very, very interesting. The other, I want to cascade one level further, which is the care that patients are receiving, meaning women patients are receiving different care for the same symptoms because of these same forces that are in play. So share a little bit about that as we sort of flip on the light at every leadership layers and clinician levels. But let's talk a little bit about women patients in the exam room and kind of what the data shows on that front.
Absolutely. So before I touch on that, I want to comment one thing on what you said about the leadership, which there's actually data that came out during the pandemic that showed the way that women were leading. It's very different from the traditional way we see leaders in healthcare, the patriarchal telling someone what to do. It was much more collaborative. It was much more communal. And that actually had better patient outcomes. It had better outcomes in the ICU. And it was a better leadership style. And people felt more engaged and more felt more inspired to follow those types of leaders. So I want to emphasize that point. So talking about the care that's being delivered, I mentioned the study that showed that women surgeons had better mortality and morbidity outcomes when operating on patients. What often happens with women patients is their symptoms are discounted. There's all this stuff on Twitter or X right now talking about how IUD placement is very, very painful. And women are just told, oh, you'll be fine, take some Motrin, but it's actually quite painful. And so a lot of female or women patients' symptoms are often discounted. And so they feel more comfortable oftentimes going to a provider, a physician, a nurse practitioner, somebody who is a woman, because they feel their symptoms are going to be more listened to and understood just because of historically how they've been treated. And there are studies that show this. There are studies, as you mentioned, about chronic disease that show women physicians actually do their due diligence and they don't discount these symptoms. And women in general get better treatment because of that. Because one, the women are listening and they're not discounting their symptoms as, oh, she's histrionic, which is what has stereotypically women have been called for years. And, when you look at women of color, this is an even bigger issue. I mean, we talk about maternal mortality in the Black population, how it's so much higher in this country. I mean, that goes back to years and years of systemic racism, where it used to be thought that Black patients had a higher pain tolerance. And so we're seeing even in that case, women are more likely to be empathic and be able to actually identify these challenges. So the data is there. It's very, very clear that women physicians provide exceptional care and their outcomes are also exceptional.
And I want to go back to that area that you talked about in terms of leadership, because it is so vitally important right now. And the level of engagement, meaning engagement is, I'm going to stay here. I would access my discretionary effort. I would recommend this place. And it's the healthcare workforce engagement is critical. It's a dependency for all the things we want to achieve in healthcare. And about 80% of that engagement is rendered by how the organization is being led. And the command and control paternalistic style is the hands down least effective way to engage our people. So this composite of how do we lead in a way that allows us to engage our people so they stay and deploy discretionary effort to help us achieve things is a requirement for the culture of healthcare systems and American healthcare, which kind of sucks right now, quite frankly. And so, if women have a greater leaning towards collaboration, psychological safety, lower authority gradients, honoring people for what they can contribute, giving cues of inviting participation and contribution of frontline folks to raise their hand to solve solutions, that's a really big deal that we're not fully tapping into by not dismantling some of the biases that we have right now that are locking women in and not unleashing what they have to contribute.
Agreed.
So
absolutely. Well, I was going to say, I absolutely agree with you. And, it really is interesting because we saw this leadership throughout the pandemic really be highlighted across the world, right? The women who were leading, the Prime Minister of New Zealand was doing a phenomenal job. And she led in a very different way than most men would lead. And there was actually data that came out at the beginning of the pandemic showing that the countries and the states that were led by women actually had better outcomes. They had better survival. Because a lot of it was really based on this empathic leadership. It was based on collaborative leadership, on listening to the people around you. And it was really those stereotypical feminine traits that people say, oh, she's not a good leader because she collaborates too well, when in the past it was, oh, you have to be authoritative and you have to, lay down the law. There are different styles of leadership, but what we're finding is these traditionally more female gendered leadership skills have actually been the ones that actually can provide transformative and visionary leadership. And the McKinsey study that came out, or the McKinsey survey that came out, showed very clearly that women are really running a lot of the committees and focusing on the things that get organizations awards. It helps with retention. It helps them with people keeping people's mental health okay. That type of work is so important, and it was never focused on as much in the past. And I think we're transitioning towards that and realizing how important that type of leadership is.
So I think in summary, we've sort of very, very briefly articulated some of the consequences of gender inequity that persist today, and some of the lost opportunities in the exam room, in leadership levels, and general contribution to cultures and effectiveness of how we lead, how we collaborate, and how we treat patients based upon a composite of skills and behaviors and dispositions that may be more prominent with women physicians and women care team members than with men. One of the areas that I'm also interested in is if you look at the data in regards to the probability of burnout right now among women, nurses, physicians, and other members of the team. And again, women are almost 80% of the total healthcare workforce. So this is a big deal in terms of how do we dismantle the biases that we see. Why do you think that is? I mean, obviously it's in part related to the circumstances that persist in healthcare organizations today that you had articulated, and that's part of it. But why is there such a striking difference in regards to burnout right now among women versus men?
So there's a couple of reasons. So one, we actually published a paper on this concept of the implicit bias, imposter phenomenon, or imposter syndrome, and burnout kind of cycle. And what happens is there's implicit biases that we all deal with, where people assume you're pregnant, so you don't want a leadership role, or they assume you're a woman, so you're not going to want to do this, or you're a woman, so you're not going to be a good leader. So those are the implicit biases that fit in. Then many high achieving women have underlying imposter syndrome or imposter phenomenon, where they don't feel like they're good enough. And when you're working 20 times harder and not getting the accolades, not getting the awards, getting paid less, it fuels more of that imposter phenomenon. And then all of this leads to fueling burnout. So that's one really big component, where you have this system that is beating you down. No matter how hard you work, it gets harder and harder to achieve the things that you really should be achieving. But then there's a flip side of that, which is stereotypically the majority of the home work, the societally, the work that is deemed to be, domestic work, is still predominantly done by women. I will say men are stepping up to do more of it. My husband is wonderful, and he's stepped up a lot in the last 5 to 10 years to help with it. But there's still, the default always is the women. And that adds an added burden. So when I give talks about these things, I always tell the men and women, everybody in the audience, I say, this isn't just something that's taking place at work. It's also providing the support at home. And it's up to institutions to provide things like, maternity leave, areas for pumping, childcare. So all of those types of things are really a key, because I'll tell you, I have 3 children. I'm the one who's doing their activities. I'm figuring out carpools. I'm figuring out lunches. I have to write a letter for the teacher for tomorrow. Those are all the things. That's a mental burden that's on me. And my husband helps where he can, but I'm always the one who gets the emails. Even if I put his email, they always default to the mom. And so there is so many different things that exist from a society standpoint that also are adding on this extra mental burden. And then during COVID, I mean, my kids were doing virtual schooling. I was doing meetings where all three of my children were on my lap while I was talking to the head of our cancer center. And now, when they went back to school, my cancer center director asked me every time, "Where are your kids?" Because he's so used to seeing them on meetings with me.
Right.
But that's the whole point. I mean, there's memes and videos and TikToks out there of showing dad working from home and, he's doing his work, mom's bringing him coffee, and mom's working from home, and there's like chaos, tornado around her. So I think it's not just what's happening at work, it's also what's happening at home.
It was interesting. Another one of the articles I read actually quantified that women do on average 102 more minutes of domestic type work per day compared to their male counterparts. That's kind of a lot when you're already working full time. So no, I totally get that. So what's interesting is that if you approach people in healthcare and you say, we would like to create a place that has equal opportunity, equal pay for equal work, uh, open channels to become everything that you want to be, how you want to contribute, how you want to work, and your ability to really pursue the things that matter most to you without encumberment, if you will, that we've spoken about that are often implicit. I think everybody that I know would say, yeah, we want that. We want that too. Meaning it's not a deliberate, let's suppress women and their contribution and their experience. It's just implicitly there, which is part of implicit. So given that that's, I think, a circumstance and part why women are so frustrated and often spinning, and you can articulate it in your personal journey, what do we begin to do to begin to dismantle this persistent gender inequity that is having massive consequences on culture, on those providing care, the quality of care that we can provide, and is burning out 78% of our healthcare workforce? What steps can we take individually to begin to dismantle this?
So first, when you talk about equal pay for equal work, you have to think about how are we being compensated. So unfortunately, a lot of the equal work that's being done isn't actually equal because a lot of the work that women are doing is not compensated. So we need to think about our compensation structures and compensation models.
Mhm.
That's number one. Things like equity work, things like committee work, things that really is necessary for institutions to thrive and survive, that needs to be compensated work. That is number one. So we need to reimagine how we compensate. We also, it's interesting, there was a study that came out that looked at the RVU reimbursement for, I believe it was urology surgeries versus OB-GYN surgeries. And the reimbursement rate was higher for a urology surgery that was much simpler, that took less time than a more complex OB surgery. So this systemic challenge is so deep in our systems that it goes down to even a 15-minute urology surgery is compensated at a significantly higher rate than a 2-hour, very complex obstetric surgery. So if we really want to make change, we need to get as granular as looking at how we're compensating from an RVU standpoint, but also from a bigger standpoint of where is the compensation going, because these compensation structures were created when women weren't in the healthcare system. So that's number one. Number two, this needs to be a solution that is made and come up with all genders at the table. You can't just have women coming up with the solutions, because that also drives burnout. When women are the ones on all these committees coming up with solutions and then nothing is changing because they aren't in the leadership positions to actually drive change, that is incredibly frustrating, and that drives burnout as well. We also need to be really thinking about how we support these women when they need to go on maternity leave, if they have children. How can we provide childcare? How can we support them in that level? And at the end of the day, we need to be sponsoring women who aren't in our circles. You need to be thinking about people who you don't normally think of for opportunities. I do this just as much as everybody else. We think of an opportunity, we say, my friend so-and-so would be perfect for this, and lo and behold, that person gets the opportunity. That is how life works. If you want to really change things, we need to be very intentional in who are we asking to lead? Who are we selecting for these opportunities? And how do we get a diverse set of voices with diverse expertise in these different positions? And it's got to be from the top down, because we need diverse voices at the table in the planning part, but also all the way up to leadership. So it's really being intentional and thinking about how can we drive change by sponsoring people for opportunities, for awards, for nominations, and then doing a deep dive into where the money is going and how we can really disseminate it more equitably.
Those sound like very actionable sort of things. Some of them are harder than others. But I think that there's two things that I think we can immediately apply from this conversation today. Number one is raising the flag of awareness. Awareness diminishes perpetuation, right? When we see what the data is in regards to how women are leading and the impact that could be creating, how women are providing care and the outcomes that they're creating, how there's a differential in terms of opportunity and pay that is quantitative, real, and now highly visible and known. All of those begin to turn the light on of awareness, and awareness is the beginning of a change process. Without that data, without that voice and advocacy and continuous communication of, we have an issue in regards to how 78% of our workforce is being in our industry. So number one. Number two, I want to talk about something that you actually built some content for us on, becoming an upstander. And I watched the coaching tip today, and it was so good. It was about, becoming an upstander, which is, I can become an upstander where I am, where I work. Talk to us a little bit about that and the contrast of the bystander, and how we can take that to become advocates for not only gender inequity, but other inequities that occur in our world right now.
Being an upstander is the easiest and hardest thing you can ever do. I say easiest and hardest because it's something you can do every day. And I say hardest because I hate conflict. And so for me, it's always hard for me to be an upstander, but it is so easy. So I'll give you a perfect example. You're in a meeting. Jennifer has an idea. John then reiterates that idea a few minutes later, and everyone starts patting John on the back for this amazing idea. Easiest thing to do is say, hey, Jennifer, I loved the way you presented your idea of X. John, thank you for summarizing it so well. Jennifer, can you share a little bit more of your thought process behind this and how you think we could implement it? So you are an upstander because you're bringing it back to Jennifer. You're not making John feel bad for trying to steal her idea intentionally or unintentionally. And then you bring it back to Jennifer. So that's an easy way to be an upstander. Another easy way to be an upstander, I tell my students this: if you're on rounds or if you're in a situation and somebody is yelling at you, or somebody is being mean to you, or somebody is saying something inappropriate, if there are other people in the vicinity, they should just start moving closer to you. They don't need to say anything, but pretty soon this person is going to be berating not just one person, but an army of 3 to 5 people who've all of a sudden gotten into proximity with this person. That is the easiest way to be a bystander or an upstander, because now there's all of these people who this person is having to deal with, as opposed to just yelling at one person. Another way to be a great upstander is, before I go into meetings that I think might be tense, I usually ask a friend or a colleague, if they're already going to be in the meeting, I warn them, this may happen. If someone says something, would you mind standing up for me, or would you mind saying this? If there's not somebody in the meeting who I see could be an upstander for me, I sometimes ask to bring somebody along to make sure I have that ally in the room. And then again, give them a little bit of prep work and say, if we could potentially if you could say this, if this happens. So being an upstander, it's so important if you can do it in the moment, because it can really completely change the trajectory of the way a conversation is going. And by nipping something like that in the bud in the moment, it also might be a learning lesson for the person who is doing the aggression or doing the inappropriate behavior, and maybe be a lesson for them as well down the line.
What's interesting about becoming an upstander, because you and I can speak about the importance of gender equity and what personal commitments we have and advance the data that shows that there's big disparities. But unless it is able to diffuse across a large group of people that use their awareness to change behavior and make policy and opportunity changes, then it's just me and you just going blah, 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 right? And what's interesting to me in my sort of self-reflection and watching your coaching tip was, what are the underlying values that drive the willingness to become an upstander? You have to really believe it, because in order to become an upstander, which is I'm going to stand up for a belief, I'm going to stand up for a person, I'm going to stand up for what's right, and I will be a force for what's good and right and just wherever I may be. And you populate an organization with enough of those people, you can begin to really shift how the organization behaves. But in order to do that, you have to have a value system that's pretty compelling, meaning I believe that people of all sorts of different types and genders should have equal opportunity to the life that they seek. That's pretty important personal reflection. And clearly that light burns very bright for you. So much so that you've done all the things that you've done. That, like Martin Luther King had a light burning in him that powered all sorts of changes in civil rights. And you, Shikha Jain, have a very bright light. What would you encourage people to think about in terms of what they can do personally and what they should reflect on as we're facing this challenge of gender equity that is persistent and having all sorts of consequences?
First, thank you for that, and for those incredibly kind words. You gave me goosebumps. That was very sweet. I think that it's really hard sometimes, especially if you've never been in a situation where you have been marginalized or you have been at the other end of things. My own husband didn't understand a lot of the inequities that I had faced until he saw it happen firsthand. So for some people, it's really hard for them to even conceptualize that this is the everyday of some people. And so I think, like you were saying earlier, disseminating, educating, showing with anecdotes and also with data, I think knowledge is really important, and we need to share this information. I mean, I know people now who believe this to their core, who 5 years ago when I met them were like, this is all hoo-ha and I don't know what you're talking about. You know, gender equity, we achieved it in the 1960s. So I think that part of it is we need to keep disseminating information. And to people who don't understand this or who don't believe in this, it can be sometimes really hard, because it's like one of those things where if you've never experienced it and you've never seen it, you think that people are just complaining. And I get that, because I was once there. I did not think gender equity was a problem in healthcare growing up, because my dad is a surgeon and he, in my mind, was very equitable. And so that was my vision of what healthcare was like. And it wasn't until I got into it and things started happening that I realized how wrong I was. And I think that it's really a personal reflection where you have to think, okay, where is my privilege? I'm a privileged person. I come from a very sturdy home. I have 2 loving parents. I'm very fortunate. I have a wonderful family, my husband, my kids. So that's a place of privilege that I come from. And we have to recognize and understand our own privilege. And then when you're doing some introspection, you really need to think, every single person comes from a different background. Even if they look like you don't know their life. You don't know, if they were living in a car growing up. You don't know if they were in foster care. You don't know what life experiences have led them to where they are today and have really driven what the person they are. And so for me, whenever people say to me, well, I don't think this is right, I don't think this makes sense, like, we don't need to worry about equity, I first turn it back on them and I say, I want you to realize that your experience is different from this person's experience just because of how you look. There's nothing you can do about it. And it's not something I'm penalizing you for. I just want you to understand that you're coming from a different perspective. And then number two, really reflecting on, if this was my family member, would I want them treated like this? If this was my loved one, would I want them treated like this? Would I behave like this if this person looked different or sounded different? And getting that beginning idea is, I think, a really good way to start thinking about these things. There's so much in the news these days about people being anti-DEI and anti this and anti that. And I really feel like we shouldn't be anti any of this. We should be for people, and we should be for being good humans and following the golden rule. So go back to kindergarten and think about what you learned in kindergarten, which is treat others as you would want to be treated. And that is the foundation of everything that I do. I treat everyone the way I would want to be treated, regardless of their background or their history, because to me, we are all people first. And then our experiences in our lives are what drive us to become who we are. And it's up to each of us to identify our own implicit biases and then use that to try to drive change, whether it's in our own lives or in other people's lives on a broad scale. We really need to think about ourselves and how we lead and how we exist in this society, because at the end of the day, we are a society and we should all be helping lift each other up, not trying to beat each other down.
Well, that's a beautiful place for us to pause and end here. I think that Shikha, you have done so much good through your voice and through your actions and your lobbying and your voice out in the community. You've helped me grow in terms of my awareness and how I approach life. And I have a daughter, and I want a world where everybody from all sorts of different places is able to walk forward and contribute their best without undue or unfair weight that our world can cast upon them. There is some transcendent simplicity. And the people in my life, I will treat with honor and respect. I will know their story the best I can and give them the best opportunity for them to become their best in their life. And what a great way to live a life. To be able to help and support and lift people and to mentor people and to guide people. I mean, it's good for them, clearly, but I think it's equally good for us to be able to say, I was a light in the world and I was able to help and support somebody that maybe had a barrier, and I got that barrier out of the way, and look at her go now. Holy smokes, it's awesome. And so that's a beautiful thing to be able to be a participant in. And I would also convey that we have full dominion over becoming that person if we choose. We've got full control over who we are in this life. So that's powerful. So Shikha, thank you so much for all that you do, for being a guest on this. And I want to give you a chance real quickly to speak about the summit, Women in Medicine Summit. Share with us a little bit about that, and then we'll close out.
Yeah, so I started the Women in Medicine Summit several years ago. It's our 6th annual summit this year. It's in Chicago at the beautiful Drake Hotel, September 13th and 14th. It is a CME conference, and our speakers are transformative. I mean, we have some speakers who are also a part of Practicing Excellence and have done some of your, have done some coaching for you guys, some sessions like Lieutenant General Mark Hertling and Dr. Mark Shapiro. We would love to see all of you at the summit. I've been told it's a transformative experience. I'm a little biased because I do run it, but objectively, some of the feedback we've gotten is that it is a transformative conference. So would love to see you guys there if you're able, and early bird registration is open right now.
Fantastic. Fantastic. Well, we'll send out a link for that as we send out this recording. Again, appreciate you, your contributions, your spirit, your bright light, and of course, your presence here.
Thank you so much for having me.
Okay. Thank you, everybody, for being here, and stay tuned for our next episode of This Clinical Life coming up soon. And we are out.